Good morning, good afternoon, good evening, everyone joining us today. My name is Odoro Tieno. I'm your moderator for this session, for this inaugural webinar from the Quality Improvement and Patient Experience Working Group of the Acquire Community of Practice. On behalf of this working group, I'm excited and thrilled to welcome you to this Quality of Care series. Our topic today, we are looking at how to build a culture of patient-centered care and with a specific focus on the role of leadership in driving behavior change. Today marks a very significant milestone in our journey. This follows the establishment of the community of practice as we know it, following the Acquire QA Leadership Workshop that was held in Nairobi on building quality improvement into the African health system agenda. As we start this journey today, we are united by our shared commitment to improving patient safety, especially as we observe this year's World Patient Safety Day coming up on the 17th of September. This session will mark basically the first activity in our efforts to kickstart and dive deeper into enhancing patient safety and quality improvement across the continent. Thank you for being part of this community. We appreciate you and we welcome you. Let us all make this journey enriching and as impactful as it can be. This is our program for the session. This is our program for the session. On the chat box, kindly, you'll be able to connect with us and you'll be able to follow through the discussions. We will share the programs and the slides on the chat box, so keep checking in. And kindly, just by way of your registration, kindly tell us where you are, write your name and location and maybe your role in the chat box. And we'd like also to hear from you, what have you found effective in driving management and managing quality of care and patient safety within your organization. We'll also want to hear from you what aspects of this webinar basically attracted you and made you think of signing in. A few rules that we'll be looking at in terms of housekeeping. Please keep your microphones muted as basically to ensure that everyone else has an opportunity to speak and listen to one another. For questions, as the presentations go, we suggest that and encourage that you keep your chats or your questions coming in the chat box. And to have a wonderful experience throughout the webinar, ensure that you have a stable internet from your end. And let's respect the privacy and confidentiality of everyone else who is joining in and looking forward for a great learning experience. This session, it's CPD accredited, and in the webinar during the registration, I think you supplied your information, the registration details. That is sufficient to enable you get your CPD points. We'll have about 21 days from the day of the webinar up to the time you will receive your CPDs through the various regulatory bodies for participants in the country, in Kenya, and for participants outside the country. We'll send you e-certificates upon request through the emails that you used at registration. Let me invite Shiro or Jacqueline from Acquire to basically tell us a little bit more for those who are joining us for the first time, what Acquire is all about. Kindly.
Thank you, Ador. My name is Shiro Lande from Acquire Frontline Healthcare. We welcome you to this webinar. For those who are new to Acquire, we just want to take you through a short, run through of who Acquire is. So what does Acquire do to improve healthcare at the frontline? Acquire, we do bridge the no-do gap by training frontline healthcare in quality improvement practice. How do we do this? We build the capacity of frontline healthcare workers in quality improvement. We create an enabling environment for evidence-based quality improvement practice within institutions. We do foster a community to drive uptake of QI practice. If you'd like to know more about Acquire at the end of your presentation, you're welcome to go to our website and learn more about Acquire. Thank you, Ador. I'll hand it back over to you.
Thank you, thank you, thank you. For this session, we are going to look at how do we build the culture of the culture of QI practice, basically looking at with a specific focus on the leadership's role. And to help us go through this, we've got three wonderful presenters who are going to take us through the session. And we request and encourage you as they present, keep your questions coming in the chat box, and we'll be learning together. So the way we've structured the session, we are going to listen from the organization level, and we'll be listening on how the leadership at the organizational level can build or drive behavior change for quality improvement and behavior change. To take us through this, we are going to have and listen from Ms. Evelyn Gadoni. She is a quality assurance officer with over 6 years in healthcare and a bachelor's in medical laboratory science from Masinde Muliro University of Technology in Kenya. She has enhanced healthcare at Premier Hospital, where she's currently practicing, by identifying improvement areas, implementing quality controls, and leading patient safety initiatives. Her achievements include developing a quality management system and significantly reducing system-related errors while fostering collaboration and maintaining high patient care. She is going to take us through and share with us few insights on how leaders within the organization level can drive behavior change for quality improvement. Welcome, Evelyn. Can take us through.
Thank you, Edward, for that introduction. I'm very excited to be guiding us through some of the things that have worked for us at Premier Hospital in terms of driving and building a quality culture. So basically, when we come to leadership, and especially when you want to inculcate a culture within your organization, the first step is for you to really be able to understand why this is so important. It needs to matter to you, because then you're able to communicate clearly to the rest of your staff why it is also so important. And I think they keep saying this in marketing: you can't sell what it is that you don't own. So a better understanding and a drive and a passion for quality will then be able to be seen and cascaded to the rest of your staff. The other thing that you can do as a leader to build culture is to be able to be a good communicator. And here you need to be able to draw a clear vision of how you want quality to be in your hospital. What is the end goal for you? Are you able to set that tone for the rest of the hospital? So what is the why? What impact do you want from this? What are those outcomes that you want? How do you want your errors to look like? How do you want your efficiency to be? What will be the effect of this in the service? And how then will you be able to do these things? So it needs to come out very clearly from you as a leader on the why and the how. You find that you'll be able to get more people on your boat if you can communicate this clearly. Then what does success look like to you? Are you able to paint that picture and guide people along the way? And then how will you be able to know that you're on track? So as a leader, you should be able to clearly map out the path of how you'll be able to even know that you are on track. And since you have now established those measures, then you come to the third point, which is awards and recognition for your staff. So how will you be able to then give this positive reinforcement? So that's one of the ways that you can be able to very quickly sustain momentum when it comes to quality. Even if it is something as little as certificates, even if it is something as small as recognition in a hospital baraza, those things tend to have an effect on an impact on the person who is delivering the service, because then they know that it matters to you as a leader and that their small actions are actually having an impact on the overall organization. Then we put that aside. If things don't go right, what is your tone again in terms of a quality culture? Have you created a system where you're able to tolerate what we call good faith mistakes? So this is when you have a staff who came to work energetic to do the right thing, but then things did not go as was planned. So do you have a system that you have been able to establish to tolerate good faith mistakes? Are you able to then establish what you call a just culture, meaning that you do not encourage negligence, but you hold people accountable for their actions and for things that they are delivering to the patients that you serve? Then you come to the next key point, which is patience. When you try and merge quality and the patient's experience, you need to keep remembering that the person that you're serving is king. So how are you gauging their feedback from these people? So we have been able as a facility to incorporate patient feedback as an improvement tool. How are they accepting or receiving our patients, our services? Is it actually leading to better outcomes for them? Are we achieving those perceived elements of quality, as we will come to see later? And then one of the other key highlights in terms of building a quality culture is to be able to know how to guide improvement. Are you able to tell in terms of the processes, how can you be able to lead the team? So this is very, very basic in terms of showing them that they can start small and, being able to pick things that have a high impact, so that then the success rate and the motivation is high when they see that they can achieve even small things, and they can be able then to replicate this even on a larger scale to more people and to more service area points. Next slide. So we've talked about patient feedback. So using this as a tool for improvement, how do you then make it part of your QI processes? So the first point I would suggest for all leaders is to have multiple channels of feedback. So you could be using physical forms, you could be using QR codes, you could be using suggestion boxes or social media platforms. So you need to have channels that will enable you to get feedback from all the populations that you're serving, especially since most hospitals you'll find are appealing to people of various cadres and areas of influence. And a good thing to note here is that you should get at least 30% of feedback from the people that you're serving. That will give you a good catchment of the quality of your services and how your patients are perceiving them. Then when it comes to the people who are working in the hospitals, you need to be able to make it easy for them to actually collect this feedback. So you need to integrate this with processes. So when it comes to your patient journey, at what points are we getting this feedback? Is it just at one point, or are you encouraging that one section only of, maybe the tail end of the patient journey is where you get the feedback from? It needs to be very clear and very, very well integrated with your processes, so that then you don't have any missed opportunities. And then if you don't plan well, then you're planning to fail. So you need to have a structured way of how you will be reviewing now all this feedback that is coming, and how will you be able to address them? How are you escalating things if you're not in a direct line of addressing them? Are you able to assign them to the correct people? And what then is the way that these things are escalated even down to the patient? which brings us to the next point of communication. When we look at patients and the pain points for most patients, you'll find it is an issue of communication. Nobody told me how long it would take. Nobody told me that it would be painful. Nobody told me, nobody listened. So your patient feedback should be incorporated in such a way that they get the feedback. And especially for small issues like pre-authorizations, maybe it took too long. You'll find that it's issues of just explaining that there will be a small delay here. There'll be an issue of sorting this, but we are in the process of doing it. So everybody just wants to be kept appraised of the situation. So if you're able to cascade this down to your frontline workers, then you have a better chance of solving these issues and achieving success with patient feedback. Then gauging improvement and creating long-lasting change. These two are very interlinked. So like we said earlier, you should be able to see improvement if you incorporate quality improvement in your processes. Maybe you had in your first quarter 10 complaints on one particular thing. You should be able in the second quarter to then be able to say, okay, these complaints have been reduced by this much. And then you're able to now inculcate this into your culture of actually listening to the patients and actually looking at how you can incorporate their recommendations into your work. Next slide, please. So quality improvement and patient-centered care does not come without its own set of challenges, but quality improvement is put in such a way that if you have the right mindset, you will be able to overcome this. So working in a private hospital, the biggest barriers that you will encounter are the three that I have highlighted there, which is a possible knowledge gap, or an issue with time and resources, or not being able to communicate what is in it for the healthcare worker. So when it comes to these barriers, what is your approach as a leader? Are you able to give guidance to the people that are working in your hospitals? Or are they able to bring challenges to you and you're able to escalate them and to sort them appropriately? So when it comes to the knowledge gap, provide as much training and as much information to your healthcare providers as possible. This can be through CMEs, through in-person trainings, anything that you can use to be able to build up that knowledge gap. And another thing that you might face, and especially maybe if you're in the private industry, is an issue of attrition. So how then have you incorporated all these processes so that there is a seamless transition from one lot to the next, so that things are not lost and your culture is able to be maintained? Then in terms of time and resources, you'll always get people saying, you know, quality takes time. Quality is so lengthy. You need so much resources. So are you able to communicate the simplicity of quality and the idea of CQY and Kaizen, that you're taking it step by step, that in terms of resources, even your healthcare workers as a resource are able to see how you can improve. And the last one is what's in it for me. We need to, as leaders, recognize that you need to communicate the relevance of why you're asking people to have quality as a culture. So you need to be able to communicate that that quality will eventually lead to better outcomes for the patients, which will lead to patient satisfaction, which will lead to reduced errors on their end, and an element of operational efficiency. What this does is it creates that environment, that working environment that enables you to continuously reproduce this good work that you wanted to do in the first place. So I think that is in a nutshell what I wanted to share with you today. Basically, it needs to matter to you, communicate it appropriately, award and recognize your people, and at the end of the day, when barriers come, ensure that you're quick and proactive to solve them. Thank you, and back to you, Odur.
Thank you, Evelyn, for that wonderful submission. Next online, we've got another wonderful person, Elizabeth. Elizabeth currently serves as the Quality and Patient Safety Director at AIC Cure, Kijabe, in Kijabe, Kenya. A little bit about the facility. The hospital is a part of a group of hospitals, about 7 now, and spreads across Africa and also in the Philippines. So that gives you an idea that we have someone who is quite experienced in directing and leading quality improvement initiatives at organizational level and even at, let's say, sub-regional level. She's managed to implement the ISO standard certification for the organization, and she has held various roles within the organization, and even as the nursing director, where she managed maternity and private ward operations at the hospital. She's contributed immensely in the primary health initiatives at AIC Baraton Health Center. So let's welcome Elizabeth. She's also going to give us a sneak peek on what leaders should do at that maybe sub-regional and organizational level. Elizabeth, kindly speak to us.
Thank you. Thank you. I'm truly humbled to be participating in this webinar, and it is amazing that all of you have chosen to join so that we can be able to have this discussion on building.
Elizabeth, your sound is breaking. Elizabeth, can you hear me?
Care, which cannot take off unless the leadership is involved. And one of the big questions that we are asking ourselves, how clear is it? How present are you? How involved? Hello?
Yes, we can hear you, but you're breaking.
Am I breaking even now?
No, it's clear. Please proceed.
Yeah, now it's clear. You can proceed.
All right, thank you. I was saying that patient-centered care cannot take off unless the leadership is involved, and everyone who is involved needs to know where they are headed. How does it look like for us? How are you present? Are you present in driving this agenda? How much of your time do you invest in this and in others as you're pursuing this journey of patient-centered care? How involved are you in finding solutions to the patient safety gaps that are there in the organization? Is it everyone else's problem and not your problem as a leader? Because if it does not matter to you, then they will not take it as seriously as they should. And you can only influence all the functions if you are concerned, if you are present, you're investing your time in the processes and in the people who are involved in those processes. And then you need to give direction. Is it aligned to the organization's priorities and strategy? How have you given direction on where they are going? Because clarity is key. How are we going to know that we have achieved it? What are the key performance indicators to show that we have truly achieved the patient-centered care that we are looking at? Do they trust your direction? When you give direction, do they trust your direction because you are a participant in the direction? And then giving responsibility. What is your responsibility as a leader? And do they trust you enough to allow you to know what they are doing and what is troubling them? And then do they trust you that you can be able to allow them to do what you have asked them to do without overshadowing them and basically giving them support as they may need it? And then we need to hold people accountable. Accountability cannot be achieved especially where patient feedback is concerned. When we get the patient feedback, how is it that we are holding people accountable? Do we let them know is it that they are not doing the way it's supposed to be done? And then how is it that you are participating in that accountability, giving people focusing on healthy accountability? Because when there is healthy accountability, it focuses on learning, adaptation, and it also focuses on growth. When people fall short of your expectations, can they be able to trust you enough to know that even when you're holding them accountable, you're more concerned about their growth, you're more concerned about how much they are learning and adaptation to the current situation? And then information, giving them information. What do you ever ask for feedback from them? How do they feel about what you are implementing? How do they feel about what is happening on the ground? And then how is it that you're supporting them? That feedback, what are people saying about us, and how is it impacting our big picture? How is it impacting what we wanted to see at the end of it all? And then when it comes to maintaining the culture, how do we overcome the barriers that have come as a result of the feedback that we have gotten? How is it that we overcome the barriers that are holding us back from experiencing a total patient centered care? Celebrate even the smallest of wins among the teams. Make sure that they know that you care, that they are putting in their best foot forward, as opposed to when they only hear from you when things are going wrong. And then when things are not going well, when it comes to talking about what we are not doing well, own the good and the bad as a team. Learn not to throw your team under the bus. When things have gone wrong, we did not do this well, we did not do this as we had expected, we did not achieve the outcomes that we wanted to achieve, but there is hope. This is what we can do moving forward, making sure that you are addressing the shortcomings, but you're also appreciating the good, which in most circumstances is usually the most, even when the things have gone wrong. And then identifying the gaps and making them continuous quality improvement projects, taking small projects that have got big impact in the results that you're looking for. And then that way you will be able to maintain the culture that you have built of patient-centered care. Thank you.
Thank you, Elizabeth. That was wonderful. And I still request you, let's keep the questions coming. We'll have a look at them. Next, we are going to listen to another wonderful speaker. Yes, we are going to listen to another wonderful speaker. He currently serves as a CQI lead for USAID Stawisha Pwani project in the LVCT program, LVCT health program or project. For those of us who are joining us outside Kenya, Stawisha ya Pwani is a project based at the coastal area of the Kenya, or at the coastal counties in Kenya. So we have a distinguished gentleman. Is in practice is my senior. We've worked with him at the personal level, and quite an experienced clinician who has the QI and patient journey, a patient safety journey at heart, and is going to speak to us to see the leadership role in terms of policy. How do we drive the policy agenda? How do we look at the national, how do we wear the national lens and drive the change that we desire in quality improvement and national and patient safety at a national scale and maybe at a regional scale. So welcome, Walter. Kindly speak to us and share with us.
Thank you so much. Good evening, everyone. Yes, you've heard about me. I'll be looking at how to scale up QI through multiple healthcare facilities and how national level policies and guidelines can enhance patient experience, and also look at a few challenges that come in with this level of implementation. Next slide. So quickly, looking at quality as everybody's business, as WHO puts it, the strategies that we can put across can be divided into two levels. One is at organizational and subnational, which is county level, and also now the national level. So at subnational level, which is county, I want to articulate that my colleagues who've spoken before me have given the journeys that organizations, facilities can actually work together to be able to work the journey. But now as we increase and go up the ladder, at county level, we would like to see, this also applies at organizational level or facility. Include QI in your organizational strategy. If you have an organizational strategic plan and you have organizational values and organizational objectives, make sure that quality improvement and patient experience is part and parcel. I'll be very candid. Leaders need to implement the strategy, and that strategy really informs how the organization will achieve certain deliverables within a certain period of time. Having included in the strategy, organizations have a work plan. Counties have our annual work plan included there, so that as you implement, you're implementing what you promised to the county men and women and actually the users of the health as a social service. Equally to that, make sure you're able to quantify quality improvement measurements so that you're able to see whatever you have actually included in your strategy and in your work plan, measured and quantified. Many times we fail to quantify, and that gives us really a challenge. Equally, having put it in a measurable manner, include that particular activities of QI at individual, team, and actually organized team level in terms of job description. So if health workers are to deliver quality, if it's not in their job descriptions, they will not do it. Because why? How can I do something? Because health workers think that quality belongs to somebody else, and therefore it's not part of their job. This is very important. Equally in quality, you have to work with teams, not individuals. In fact, if you implement quality in an individual manner, it can work against, where people can start lynching each other. So please work with teams. It could be teams at county level, teams at sub-county level, teams at facility level, even teams at departmental or work improvement level. And when it comes to actually now implementation, start small, make it simple. Quality seems to be difficult to be understood by many people. How do we do it? Start with 6S. Then now go to processes at departmental level. Whatever documentation that the departments are implementing and they are documenting, please start with that. Data at department level. And then having implemented several quality improvement journey, which is CQI or Kaizen, overally, then there will be total quality management if implemented in scale, because it starts small. And next slide, Edward. Sorry,
Lejana,
someone is,
kindly mute. Lejana, mute kindly.
Please mute. Sorry. So that was at not at the at what you call organizational or county level. At system level, where we are looking at things in a more bigger picture, there is a journey of quality over the years. Since 1890, before that, there was quality 1.0, 2.0 between 1890 and 1940. After that, there was quality 4.0, which is now between 3.0, which is between 1940 and 1995. And then 4.0 between 1995 and last year, 2023. And then quality 5.0, which is from last year to date. in quality 3.0, it says focus on people, processes, and technology. I want to abbreviate PPT. What happens is quality to be institutional at the system level, you focus on the people. The people could be the beneficiaries, the patients, the health workers themselves, or even the leaders. Let them be part of this focus. If quality does not matter to the leader, then nobody will achieve anything, even if we give the best to the clients. If it's not documented, we will not be able to achieve. Process is the services that we offer, and use technology to document these services, so that what happens is you will be able to measure in a broader sense. Many people are trying to implement quality. We need to have a technology-driven quality so that we document, separate human interference on the same. Look at in a health systems way with various interconnected areas. And when you do that, you'll be able to implement. But again, work with existing structures, both at national level, county level, sub-county level, and also to the facility. Next slide. Equally to that manner, when you look at now establishing the performance of quality quantifiably, please set targets as per level of facility. Level of facilities differ differently, and therefore allocate the quality indicators and projects as per the level. Level 2 could be different than level 5. Document the same on a QI dashboard. That will be able to achieve even measurable, independable, and visible to all, bringing accountability. Leaders need to support, speak about quality from morning to evening, work with the team. This is the way to go. Utilize mentorship and coaching by peers. Please mark this. It is not about supervision. The namings that we practiced before can be negating. And therefore, team effort, mentorship and coaching is the way to go, where you don't blame. Establish the culture of quality by not blaming people. Don't punish people for having made some mistakes. Let them be lessons to learn, and let them have the correct attitude of saying, yes, I can do better tomorrow. Next slide. And therefore, having looked at this, I want us to look at the national level. At national level, provide an enabling environment for all stakeholders. Don't negate. And then with guidance and policies, with guidelines to able to operationalize QI. In addition, strengthen technology. Remember, across board, technology for documentation and also for capacity building. How, again, we can be able to use that to disseminate best practice and learning across, so that what works in one region can be adopted in another. Equally, establish a national annual award and recognition. If you do not celebrate at national level, we need one unifying factor. I want to repeat, and I quote something in the Bible about Israelites and Moses leading them. And when they were getting injuries because of snake bites, God asked Moses to make a bronze snake so that when people look up to it, they get healed. We need a national quality award where everybody would look up to that quality award, and then encourage and motivate health workers to deliver quality even to the clients they serve at the smallest level possible. With that, standardize the measurements so that indicators cut across. What is priority for the donor, for the county, and for the national government need to be put as part of that quality, looking at the performance across board. Equally involve the users, both patients and everyone that is working in the health space. Finally, looking at my last slide, I'll look at what challenges do we have. Next slide. The challenges we are looking at national level is multiple. Too many quality models that we're implementing, and everybody's running with one of their own. We need to make these quality models interoperable, where we can learn from each other and we can be able to make simple, approachable models that can be scaled and owned by everyone. One important thing is that sustainability is key because funding is twinkling, and therefore we need to look at ways that can be county government-led, stakeholder-led, not necessarily led by donors, because funding is going down. Adopt technology. I will not stop mentioning technology. There is a lot of inadequate adoption of the same. We need automation. We need to digitize. We need to go now to personalization of quality, because when we have digitization, that improves on data and the quality, and therefore quality can be measured at that bigger scale. Too many indicators. We need to now allow for smaller area of measurement of quality, even at the department level. One department can measure quality at their level and still bring out quality. We don't need to do all of them at once. We build up the quality from the smallest steps. Dissemination needs to be able to standardize so that we use technology through training to be able to share the standards, because quality is based on the standards, both national and international. Inadequate training, we need to really strengthen this training. Acquire, for example, I've taken people through some short courses and people took it seriously. This is how to go. Use virtual online training and it can be able to work. I still again repeat, lack of a national reward and recognition system that can catalyze adoption across board. Lack of ownership by stakeholders, because when one platform is here and the other, another partner may say, I would not want to use because it's not ours. It's not easy to establish a digital platform, so it's quite expensive. We need to look at ways of creating interoperable systems through the digital superhighway. And with all this, national level need to coordinate quality and leadership so that we can run together. We can achieve this as a country, as a region, in wherever country you are, you can achieve by coordinating this at a national level. We have all the guidelines, we have all everything, and we can do it together. Thank you very much.
Thank you. Thank you, team. That was wonderful. We've listened to Evelyn, we've listened to Elizabeth, and we've listened to Walter, and they've given us some very great submissions. I'm looking forward to your questions in the chat box.
Hi, are you too?
Hello, is someone speaking? So if you've got a question or a compliment, kindly add it on the chat box. And just to get us started, I would want maybe a question for any of them. One, looking at how wide the organization that Elizabeth leads, that is AIC Kiwa Hospital, how easy has it been speaking to the board or the hospital directors, basically speaking and changing their mindset around around patient safety and quality at the hospital? So basically just an experience you may share with us. And to Evelyn, how easy has it been at your level painting that picture or painting that journey that you'd want to take the organization through? I think from your experience. And then maybe to Walter, I would wish to get maybe his experience and maybe share with the participants. How easy has it been to rally multiple cadres or multiple healthcare professionals to have a singular look or a singular front towards the approach to quality at patient safety journey? So any of them can just share the experience as I pick a look into the chat to pick more questions.
Okay.
Over to you, my able presenters.
Maybe I can go first. Can you hear me?
Yes, I can hear you pretty much. Thank you. Welcome.
All right. My experience at Kiwa Hospital has been an encouraging one, because first and foremost, the quality journey was a strategic direction. The hospital management decided to use quality as a tool to achieve quality of care and patient safety. And so it hasn't been difficult to have the conversations that need to be held to ensure that we are doing what we are supposed to do. I think it has been easier in terms of even cascading it down and then picking it from the grassroots and bringing it up, and therefore, hence, the impact that we have had to be able to achieve patient-centered care because of the leadership being totally and truly involved. So my experience has been that when the leadership already knows where they want to go, have made it very clear, it is part of the strategy, and there are objectives that are being monitored that are related to QI, then it becomes very easy to, it becomes easier to achieve, because quality can be a difficult journey if people do not understand the direction that they are needed to take.
Yes, thank you, Elizabeth. Walter or Evelyn?
Maybe I can go first.
Kindly do.
Thank you, Evelyn, for the feedback on your reply. Mine will be very straightforward. I have implemented this at county level across other regions. In 2018, I did for around 40 facilities in Kisumu, Vihiga, Nairobi, and Kwale. And equally, I've also now implemented for the last 1 year in the coastal region in Kilifi, Taita Taveta, Mombasa, and Kwale. And one particular thing that works really for us in involving and working with multiple cadres across multiple facilities, over 350 facilities. What has worked for us here is the leadership support. There is a lot of support from the leadership in the county, in the project that I work, and across board. So everybody sings quality. And when the donor comes around, it also comes echoing the same. So really there is a lot of commonalities in terms of leadership supporting the journey of quality. And that has really worked. Two is work with a team. So for me, I work with a county team, and the county team really support. There is a county QI focal person across all the counties, and they are also at sub-county level. All of them have been very instrumental in the journey so far, because health workers will listen to one of their own leaders. So that is to say, I don't really own the health. The health belongs to the community, and the health workers listen to their leaders. And so county-led. Two is we set targets for each level of facility. A level 2 facility will have a minimum of 1 to 3 projects. That will be fine, but at least a community one. And then level 3, 5 projects. And then level 4, 10 projects. And anybody that goes beyond that is great. So we set targets, and then now those common goals drive the implementation, because we use data to inform the CAPs that will initiate QI projects. Finally, we work the journey of quality by celebrating the small steps. When a county and a facility and a sub-county is doing well, we celebrate, because we have a digital platform that we adopted, which is able to demonstrate QI projects across all the counties we work. And we can be able to look down to which projects per facility. That is in a nutshell. So far, it's not been easy, but it has worked for us.
Okay, thank you, Walter. As you take a breather, there is a question from Ezra Kiprotich on the chat, asking, share more on how to engage county leadership to include JD, to include, I think, CQI on the JDs for the healthcare providers. And I think for our participants outside the Kenya, the county is basically a region level. So Walter, kindly ponder over that. Evelyn, you've got something for us. How easy has it been to paint the picture or paint the vision that you'd desire to have from the leadership angle?
Thank you for that question, Odur. And as the previous two speakers have said, I've also been very lucky to have the leadership, even in this institution, having quality improvement as one of the pillars in terms of our strategic plans. And so at that level, it has already been pushed down to the facility that quality is something that we care about, and that it is something that must be delivered. In terms of my role in QA, to spread it to the rest of the facility, it was just an element of keeping on reminding people that quality takes time. It's not those things, it's not really something that you can do instantaneously, but it takes time. And the small steps of improvement is what will really get you to the main goal. And then, like I'd mentioned in my session, to also quick pick those things that are really quick wins, those things that will show, you know, an impact very fast, so that then it becomes very easy for people to now buy into the idea. Then you now have departments coming to you and saying, I saw what you did in that unit, I saw what happened, can you now come to my unit and help me get to the next level? So I think those two key things is just to remind people that it might not happen immediately, but to always just keep on track. And then when you do actually have something, a chance to improve, you pick something that has high impact, so that then it is very easy for you to build that culture of belief that QI is actually going to improve our work, and it will lead to better outcomes even for our patients. Thank you.
Thank you, Evelyn. Elizabeth, I've seen a question on the chat from Paul Ndungu, and I would wish you to basically kind of give us a look into this. He's asking, how do we involve patients as co-partners in the processes running in our facilities? Do we have patients representatives in our boards or hospital committees? And with the level of your experience, I'm trying to look at AIC Kewa Kijabe. Have you had an opportunity to co-produce quality with patients? Yes. So basically, something aligned to that.
Okay, thank you for the question, Paul.
Mwanarusi, kindly mute. Mwanarusi, okay, okay, Elizabeth, gone.
Thank you for that question, Paul. Involvement of patients, yes, because we are working with them, and when collecting feedback from them, be it questionnaires, be it interviews, be it involving them in telling us what they would like us to do better, they are being involved in the part of making decision, and then involvement in the planning of their care, being made aware of what it is that is being done for them, what are the outcomes expected, what are the likely complications expected, and when those things happen, involving them in what is the next move that we would want to do. Yes, patient involvement there is, but as far as involvement, having a patient representative on the board is work in progress, because it has been identified as a gap in our hospitals, and therefore it's something that is already in discussion, something that is being looked at to try and involve patient representatives on the board, so that then they are able to give very objective feedback where concerned.
Thank you, Elizabeth. Walter, we had that question for you on how do you work with the county leadership or the regional leadership to have QI introduced or as part and parcel of the JDs of healthcare workers. I think that was for you. And then finally, yes. For any one of us, I think Walter and Evelyn, as we'll be summarizing, just paint for us what role does coaching and mentorship have in the quality improvement journey. Take it up, Walter.
Thank you so much, Edward, and thank you also the participants for really these very good questions. One, I have two approaches. One is, remember, health workers have been working in the counties for many years, and they have their own employment terms that exist. So there are two approaches. One, there is implicit approach and the explicit approach. Implicit is the soft way of saying not documented, but you can continue to motivate and encourage them, and make them see the bigger picture and own the process. Nothing documented anywhere. So this is what has worked for us. We encourage our colleagues. We need to encourage everyone that quality is us being able to shine and achieve the best. And when we do that, that is a soft way of approaching our colleagues at county and facility level. Explicit is where new employment having a job description also get to be appraised at the end of the year. So that happening, the annual work plan informs what health workers will do. So their job description could include that. And when they are being appraised, quality becomes one of those indicators to be able to achieve. So that can work both in implicit and explicit way. With that, then it becomes easy to implement QI because it is a deliverable that's expected by the employer to be to the health workers to be able to deliver. That said, other than explicit ways, there's implicit, simple soft ways works, and that informs coaching. I want to say that coaching and mentorship is where whoever is the mentor does not come with a different level of, say, position, because coaching and mentorship is where the coach actually approaches the coachee and they are at the same level. And the coachee trusts the coach that he will not charge them, he will not make them feel inferior, but be willing to assist them and become part and parcel. And this is the approach. Say, we are doing this way together because we are not performing very well. We, remember the word we, not you. And having done that, people will be able to accommodate and listen and be able to learn and say, yes, my coach has approached me and he said, we are not doing well together and we are in this together. Then out of that, that approach changes the atmosphere and the spirit of teamwork, collaboration, and that learning errors and mistakes are learnings that we can improve tomorrow. That is what I can say for now. Thank you. Back to you.
Okay, thank you, Walter. As we are approaching the top of the hour, for our participants, anyone joining us who has dialed in, we've got a poll for you that we are going to place up. And I think our team from Acquire will post it out for us. Kindly post. We're going to give us a minute or so. We respond to the poll before we listen to the summarizing thoughts from our wonderful presenters, as we call it a day. Kindly take time, take a minute or so and go through the poll. Jacqueline, how much do we have time for the poll? A minute would be sufficient?
I would say about 2 to 3 minutes. We're quite a number.
Yes.
Yes.
Okay, let's have 2 to 3 minutes as we respond to that. Okay. Also, I think just looking at what has come through the chat, yes. Okay. As a way of incorporating patients or family members at the front line with the frontline staffs in the quality improvement journey, the approach applies from across the levels of the leadership or the levels of the management. And Elizabeth has shared with us the journey they are in to have that at the board level. That can be one. And usually, in most cases, when you have organized patient groups, it's very easy to approach the groups so that they identify a representative into the board. And we can also have this at the frontline level where we are formulating or developing our quality improvement teams and quality improvement cycles. When we have organized patient support groups or patient groups within the facility, we can also have one of them being part and parcel or making part of the membership of the quality improvement team. It takes up time, and it's not an instant event. I think Evelyn has also reminded us of that. Quality is a journey and it takes time. And it will also take time before you identify the right patient groups and how to incorporate them. Aside from that, in terms of co-creating quality, once you've designed or you have identified these patient groups, be intentional and have, let's say, feedback sessions within, in the country, for example, in Kenya, we call them community dialogue days, where we can dialogue with the entire community. We get feedback and that. You can also structure dialogue sessions with the patient groups so that you incorporate their feedbacks, their thoughts, and you are able to co-create quality within the organizations, incorporating everyone's thought and thinking across the process.
Someone is asking where is the poll, please, on the chat.
The poll should be on your screen. Yes, the poll should be on the screen. I think, yes, Joanne, we've taken note of your response. Poll should include other professionals in the list, like public health and medical lab. We will do that. I think, yes, that is the feedback that we need. And we are taking note of that. Thank you. Yes, we've seen that, Feliciana, the poll has no laboratory CADA. Yes, yes. I think we've seen that. That is well taken.
We'll close the poll in the next 10 seconds. At least we have 50% who have participated. So just another 10 seconds and then we'll end the poll.
Yes, yes. We are at the top of the hour. And as we end the call, as we end the poll, just Elizabeth, you are, yes, yes, great, great. We've seen, thank you.
Yes, Edward.
Elizabeth and Evelyn, just maybe in a matter of 30 seconds or so, you are parting shot for us.
All right. Clarity in direction is clear. Being present in the QI journey is key. Demonstrating concern allows for emotional safety, and people are able to share struggles they're experiencing or gaps that they have seen in the QI processes without fear of victimization. And ownership of the good and the bad must be a priority for leadership. Thank you.
Evelyn, in a matter of 30 seconds or so, your parting shot for us.
Okay, thank you. Mine would be to remind leaders that it is important for your healthcare workers to feel appreciated. So embrace that awards and recognitions, but at the same time be able to tolerate those errors that are made in good faith. So have that just culture in your system to be able to assure people that you have that learning culture, you want them to grow. That will be able to help you instill that quality culture in your whole organization. Thank you.
Thank you, Evelyn. Walter, in a matter of 30 seconds or so, your parting shot for us.
Thank you very much, Edward. For me, I will say for quality, celebrate, celebrate, celebrate. How do you do it? Work with the people, document the processes, use technology, mentor the team, coach the team, celebrate. Thank you.
Thank you everyone for joining us. And that is the match that we could handle within the time. And I appreciate every one of you who found time to dial in, and look forward to our next, our upcoming sessions. Over to you, Shiro and Jacqueline. Thank you so much.
Thank you to our moderator and our speakers for such a great presentation, and Odor for walking us through so well. Just a few highlights once again. As Odor mentioned, the registration process will take care of the CPD points. Kindly expect them in 21 working days. And we will be sharing a Google form through the email that you have used for registration. If you would like to join the quality improvement and patient experience group, Jacqueline will be sharing a link in the chat. This is just a small questionnaire that you can go through, and then you will be added to the group. We will also be hoping, if you can, please share a highlight, a takeaway in the chat. Would love to hear what you got from this session. We want to say good evening. Thank you once again. You can now unmute and say goodbye to each other. Thank you very much.
Bye.
Bye.
Thank you.
Bye-bye.
Bye.
Goodbye.
Goodbye. Thank you everyone for your
Bye.
Thank you so much, and bye-bye.
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 Bye.
Bye-bye.
That was great.
Bye.
Bye.
Bye-bye.
Bye, team.
Toodles.
Bye,
Adios.
team.
Is this morning?